Greetings. It's a pleasure to be here, and it's a pleasure to have this opportunity to share insights with you. Over the last couple of weeks, I've had calls from young pharmacists, especially my juniors, who've been seeking to understand whether they should transition from their level 5 or level 6 training program or their internship to a primary healthcare internship program. And the question has been based on the fact that this is a new component of our internship training program. It hasn't gained root in the terms of practice, and therefore people don't understand much of what does it entail. And if it, whatever it entails, even those who understand, the question would be, why would I go for it? Why should somebody go for that level of training and leave the level 5 or the level 6 where they feel there's already structures in place? So based on this question that has been asked to me, I decided to make this short video. And the hope of it is that it enlightens you, it shares some perspectives and my observation in terms of practice, and even the internship program being among the pioneer group who did the first primary healthcare internship rotation, so that you make a better and an informed decision on which path you want to pursue in terms of your internship and post-internship. And the key goal is we have to ensure patients have the best access to care that they deserve. And we are the healthcare providers. We are the pharmacists who deserve to give them that care. So how are we going to do that? So I hope you get the best of this video. And as you make the best of it, I hope you be the better pharmacist that you desire for yourself and that the society desires of you. So when we look at it now, as I get to the discussion bit of it, is the fact that our training as pharmacists has evolved. And when I talk about pharmacy training evolving, we know the training initially we had the 4 years of curriculum and a year of internship. That transition now we have 5 years of academic training within the universities and 1 year of internship, which is still intact. In the internship training program, we had 6 months in hospital, level 5 and level 6 majorly. Then from there, we had 3 months in a community pharmacy and 3 months in industrial pharmacy practice. In the current model of training that was officially operationalized in 2019-2020, the Pharmacy and Poisons Board provided for 6 months of hospital pharmacy training. That is still level 5 and level 6. For the 3 months and 3 months for community and industrial pharmacy training, they were both actually sliced to have 2 months of industrial pharmacy training, 2 months of community pharmacy training, and now the other 2 months that were left were transferred to primary healthcare training. And the key bit of this is the fact that most of healthcare seeking behaviors of Kenyans is to the primary healthcare facilities. It can be a level 3 hospital or a level 2 hospital. And with these facilities, over time, they've not had access to pharmacists, except for the sub-county pharmacists or the county pharmacists, who have majorly been coordinating the managerial aspect and the supply chain component of pharmacy practice. So then this means access to the medicines experts who are pharmacists in the primary healthcare facilities has not been there. So then there was a need to integrate and look at how do we now get pharmacists closer to the patients, that is one. And two, other than getting pharmacists closer to the patients where they are, ensure that pharmacists can make an impact in healthcare service delivery. And making that impact is driven by the fact that most of the patients who receive care from the public health system, they have to go through the lower levels of care, the lower cadres of practice, that is level 2 and level 3. Then they'll transition to level 4 and level 5, which are on referral basis. So if we have a pharmacist at that particular level of care, at community level, they're able to make better interventions, including the public health intervention in terms of community outreach, health promotion, and the preventive programs, and even the community patient support program that can be put in place at the primary healthcare facility. And therefore, that made it important for training of pharmacists to cater for that need. At the current moment, we all acknowledge that we are used to the training in level 5 and level 6 facilities. There's structures in place. You have a senior pharmacist who will be guiding you in terms of what you need to do, how you need to do it, and even a referral mechanism. When you go to the level 3 and level 2 facilities, that is not assured, except for the occasional call that you'll have with the sub-county pharmacists who will be attending to other matters, but would dedicate their time to be able to give you the guidance you need. But within these facilities, they don't run by themselves. They are healthcare practitioners, including the clinicians in charge, the nurses, the community health workers, and the team leads for different programs that are being run in some of these facilities. And therefore, those are people that you can learn with. Those are people you can work with to serve the communities they come from. And at the same time, it opens up the practice for pharmacists into these emerging areas and even into the public health space, where generally we acknowledge we've not taken much root in terms of delivering care in those spaces. So once we acknowledge that, then the next bit would be, what was my experiences? I mentioned at the start of this video that I was lucky to be among the pioneer group that went for primary healthcare internship. I did my primary healthcare internship at Kasarani Health Center in Nairobi County. And during my internship, I do acknowledge that the benefit of that training is there. They are not structures, as I've mentioned, and however much they are not structures, healthcare delivery still happens. So the first point of call is, as pharmacists, we are medicines experts. These facilities has medicines, and that is where you play your role as a pharmacist. First point. When you get to these health facilities, introduce yourself to the clinicians. If you make the decision to go there, go through the medicines they have. Work on looking at how is the inventory management system. Are there any shortfalls, any improvements that you can make? And then in terms of the dispensing component, because once the clinicians see patients, they'll be sent to the pharmacy to get their medication. You're not there to dish out medicines. You're there to offer pharmaceutical care and dispense medication based on that proper pharmaceutical care that is guided by your education and training. So can you interact with patients? Can you engage with them, enlighten them, understand the disease condition? Once you understand the disease condition, review the medicine that have been provided, advise the patient on how to take them if you feel they're appropriate. If not, engage the clinician. And that is going to make you stand out as a better pharmacy because you'll be delivering the value that you're qualified to deliver. As that is the first phase of it, it is not the limit of what pharmacists should be doing. And therefore, you need to ask yourself, what other programs exist within the primary healthcare system? And I would mention we have the immunization programs. We have the immunization clinics. We have the maternal care and family planning programs and all. These, most of them are run by team leads and community health workers, and even some we have nutritionists. And therefore, these are avenues where you as a pharmacist, you can go integrate into these programs once in a while when you're doing your internship. Being it's 2 months, it's a short period of time, take a week in the immunization clinic. Get to look at what vaccines are being administered to patients. How is the administration technique? What are the shortfalls? And one of the things that from the top of my mind that I could mention is some children will miss out on vaccinations, not because their mothers didn't want to take them for vaccinations. People move, people relocate from location to another. So what monitoring technique do we have in place to ensure that a patient who was being seen, let's say, for example, in Kasarani, and the parents migrate to Mandera or Garissa, or even Nyanyuki, whichever place they go, how do we ensure that they'll not be lost to follow-up and therefore they'll have access to their vaccines? Because if they don't, we are exposing them to the diseases that are preventable by these vaccines. So we need to look out for such. What intervention can you put in place as a pharmacist? Then another key thing we look at from my experience is we have the people who have non-communicable diseases, the patients who are suffering from hypertension, from diabetes, and any other asthma, chronic obstructive pulmonary disorder, COPD. All these chronic diseases need reliable, consistent access to medication because they are lifelong. And according to the current dynamics of practice and what we all acknowledge is access to medicines is not the most robust system that we have. And therefore, some of the times patients go to hospitals and the first response they're told is, we are not having these medicines, they're out of stock, and therefore you'll have to buy them from the pharmacy. It is good to say, because it removes responsibility out of you as a person, because it is not there. That is why you can't provide it. So you'll transfer that responsibility to the patient to source for it from other alternative measures. What if that patient doesn't have the medicine? Will you have delivered the care that you're supposed to deliver? Definitely not. And therefore, that is a point for you to intervene. What can you do to ensure there's reliable supply? You will not use your money because it might not be able to sustain the supply of medicine, but you can be creative and innovative. I remember during my internship program, we engaged with the clinician in charge at the facility. There was a partner who was willing to come on board, and we were looking at what are the probabilities of putting in place a patient support group. What are the chances and what would be required? Then luckily enough, we started as a patient support group instead of that also integrated the clinic component of care. So we have a patient support group where we offer educative program that is the health promotion and preventive information sessions. Then other than the promotive and preventive sessions, we now looked at how do we source for medicines for them to be reliable. The facility would have medicines once in a while, yes, which is good. But when they are not able to, we can partner with the distributors and with some of the faith-based institutions. For example, in this case, we are dealing with meds, where we could source for medicines from them based on payments from patients. If you refer them to go buy in the pharmacies, you're not sure of the prices they're going to buy them at, and they're not sure whether they're even having all that money that they need. So in this kind of an arrangement, it was agreed with the institution that we could get medical supplies for these patients on a monthly basis at 500 Kenya shillings. So it's 500 whether you're taking or drugs worth 2,000, worth 100. So based on the patient support group, this is a social safety net. And therefore, all the patients were able to access the medicines that they needed. That is a win for us, and it is a win for the patients, rather than sending them out to the community to go buy medication. Another experience that I had is with the HIV Aids Clinic. We all know comprehensive care clinics that are there in this government facility, because HIV AIDS as a disease has been affecting our communities for the last more than 20 years. Some of us have personal experiences. Some of us have interacted with patients and we need to intervene and care for them. And in one of the sessions that I had with adolescents and young people living with HIV, they were looking at what are the dynamics of society. And this is a challenge that I'm going to give you. When you have your free time, go read on human-centered design. We are providing interventions. We are looking at how to provide access to quality care to the communities. But do we model our interventions around them, or do we model them for them? If we model for them without integrating them and looking at their lifestyle, the dynamics of where they live, we are not going to serve them. And if you're not going to serve them, the impact of our intervention will not be felt, meaning we'll have failed. But if we look at it from the dynamic of what works for them, what is the ecosystem where would they exist, and how can we ensure they get the best solutions? And the most robust thing in terms of these, is that as a young person, I look at the dynamics of my life as a young person, and I look at the dynamics of the lives of these young people, where they live, and how can I help them? I remember mentioning it in some other forums as well. HIV AIDS is there, it's transmittable. And in terms of transmission, we know one of the ways is unprotected sexual intercourse. But as we are talking about it, and even in terms of our relationship, we all desire human connection and that kind of social bond. So how do I disclose my HIV status? I made a tweet on it, even on my Twitter account, there's that tweet that I shared. And in terms of the responses, most people would not disclose their HIV status. Why? Because as a society, we're not gotten to the point where we are free to talk about our HIV status. And therefore, oftentimes most people will not share about their HIV status. But that does not break the chain, because if I don't share, doesn't mean that I will not transmit the infection. So therefore, I'm putting others at risk. But at the same time, the ecosystem we exist in, we do not allow people to talk about it because it's not convenient. It's not convenient for them. They cannot share. So some of the suggestions we're having is, can we have a program where they can come as young people who are affected and infected with HIV, interact among them, because these are people who understand. We model it around them. That would be a better intervention. It could help them. So such kind of programs, young pharmacists can do that. You can be part of that community. You can intervene. You can help them. Why not? So these are some of the dynamics of what I had. Patients coming to the pharmacy, they want medicines, but they don't know how much they're going to use them. They need extra information. They feel like you are the point of care. And one of the things that, as I mentioned, the aspect of being as the pharmacy window, is that patients will go to doctors and the clinicians because that is the process. And therefore, it doesn't mean they'll disclose everything there, unless they get a clinician or a doctor who probes further to seek that extra information. But when they get to you at the pharmacy, they acknowledge they are sick people and they need help. The help they need, they don't know that all that consultation might not give them the help they've hoped for, but the medicine you're giving them is what they consider as cure. And that is one of the things that's shaping the patterns. Most people will go to community pharmacies rather than go to hospitals where they'll spend 2 or 3 hours in the queues or even more, because they know the treatment is the medicines. So when they come to your pharmacy, they ask more questions. They are open to give you more information if you probe further and seek that intelligence from them. Therefore, you are more equipped and better equipped to serve them better. Be the person who asks more questions, who wants to understand their condition, and who wants to help them. Then now going back to your question, should you go for primary healthcare rotation? Maybe for me, I would be for it, yes, but maybe not. And the key thing that you need to ask yourself as a pharmacist is, what is your interest area? What works for you and what doesn't work for you? There are people who are interested in clinical pharmacy practice. You'd say, oh, clinical pharmacy, it has to be within the level 3, the level 4 and level 5, or even level 6, the advanced facilities. Maybe yes, but not really. Because when you're dealing with a patient who has diabetes, do you know what are the diagnostic criteria? Do you know how to design a treatment plan? Can you collaborate with the clinicians at the level 2 and level 3 in the primary healthcare rotation? Once you design that care plan, can you engage with the patient to comprehend and understand that they are able to follow through with it? Can they sustain it? If you're talking about lifestyle modification, avoid certain kind of foods, can they get the healthy foods that you're suggesting? So that is the aspect on clinical pharmacy care. Some of them, when they come to the pharmacy, they're already taking other medicines from home. Medicines reconciliation. Can you engage them at that level? It's not how, it doesn't have to be in the hospital, but when they come to you at the lower levels of care, can you interact with them and have the clinical pharmacy mindset in you? It's not the institution, but it is the mindset that you have. Once you acknowledge that, you're able to intervene and offer the care that they really need from you, and that would be good from you. If you feel you're more interested in the industrial pharmacy, the other aspects of pharmacy, well and good, but then there's an interaction between the different dimensions. Let's say, for example, you're interested in the industrial pharmacy, production of medicines. The medicines are produced to be used by patients. Unless you go to where they are, you might not design the best solution for them. And therefore, the primary healthcare practice will give you the information to be able to gauge what diseases are there. So that if you become an industrial pharmacy, you are able to produce medicines that are needed by the patients in the community. If you're a marketer, you're not going to market a drug that costs 10,000 and you already understand from your interaction in the primary healthcare facility that these patients, the much they can spend on a monthly basis is 500. Let's say, for example, the NCD's patients clinic that we established. These patients can only afford 500 per month, and there are 49 patients. If you're going to sell a drug that costs 2,000, 5,000, definitely they will not access it. And if that is what you're going to sell, you have no market for that product. That information is important for you. When we're now talking about the COVID vaccines and all, why are people not getting vaccines? Can you extrapolate the data from even taking their children for the clinics? If you have that insight, you are able to design these public health programs better. And therefore, primary healthcare is not about the limitation in terms of practice, but it is the limited mindset that we look at it and the view that we have of it. And I think as pharmacists, as we're changing our dimension of practice and looking at better ways to serve patients, better ways to intervene in the healthcare ecosystem, primary healthcare practice came at the right moment. It is your opportunity to make a difference in the lives of patients. It's your opportunity to get exposed to new lines of practice, to get exposed to different ways of doing your work as a pharmacist. And therefore, I think unless you try, you'll never know what the dynamics are. You'll never know what impact you can have. But if you try, you can make an informed decision knowing I did it and it didn't work. Or I did it and I found I fell in love with it, and therefore I want to pursue this long term. That would be good for you. So I think the best thing for me, do that in primary healthcare internship program, make the best of it. And if you decide not to, it's still understandable. It may not be your thing. Go where you are. Just ensure for the 2 months that you have, you make the best of it in the facility you'll go to, whether it's a level 5 or a level 6. Make yourself of value. Let's champion for a better pharmacy practice in our country. Thank you, everyone. Hope to meet you again in the next session. Thank you.